Today we're here with Mr. Tom Hayashi, chronic pain patient advocate who works tirelessly on behalf of his wife to ensure she has a high quality of life. In his efforts, he has learned much about opioid policy and chronic pain policy and is using his advocacy to not only help his wife, but help other patients in the state of California. Talk a little bit about how you first learned about the stigmatizations around chronic pain and opioid use and how that affected the care of your wife.
Well, we first were together in 1980, and let me see when. So sometime during that year, I guess I found out she was a chronic pain patient. She had a severe case of juvenile rheumatoid arthritis, and then I can't quite remember when I learned of the use of opioid pain medications, but sometime in those early 80s. I think the view generally, at least in this area, was kind of the Hollywood, and it's kind of more the view nowadays, is that if one was to use opioids, you could become a junkie. And so she was being warned that, okay, they realized that was the only thing that was going to help her. I mean, she had gone through the usual process of trying this and, seeing a psychologist or whatever hoops they made a person jump through in those days, and getting physical therapy. But they decided that she was appropriate to get some kind of opioid pain medications, but they would really warn that, you don't want to become a junkie. So this was always like a fear that loomed in our heads for, a long time. But then after years and decades rolled by, we sort of slowly dawned on me that, this addiction thing may not really be the issue for her that they have, chalked it up to be. And but I think we were maybe concerned about opioids because we were a little concerned about the tolerance thing, because I was concerned that if she did have to have some operations later down the line, that maybe they wouldn't work, pain medications wouldn't work as well for controlling her pain during a procedure, which actually kind of turned out to be the case in 2007 when she had a hip revision at UC San Francisco Medical Center. And they did have a hard time controlling her pain. But it was, the problem was not addiction. It was just tolerance and addiction, as we know, are not the same thing. Anyhow, the tolerance is an issue which can be is typical and is expected, and if handled properly, people can come down off their medications with not too much problem if it's handled properly, and it should not be confused with addiction. I think that's a major point there. Okay, go ahead.
Talking about a patient, your wife, who was first diagnosed let's parse that down a little bit, because I think it's very important for the audience to understand. You were talking 80s, had complications, or rather procedures related to this, and up until the present. There must have been a change in how her original condition, going all the way now into the 2000s, her condition was viewed. Talk a little bit about the changing perceptions of her condition and of her use of certain medications, and how those perceptions led to different terminologies. You initially said junkie, then you said addiction, then you talked about dependency. Did you notice a use of vocabulary that changed over time along with the perceptions?
We might have been maybe we were in some kind of bubble, because she had some serious conflicts of opinion with a doctor back in 1980 that today we might call a rabid anti-opioid zealot. But this doctor's opinion at that time was, she almost discounted. She made a comment like, "Aren't you just taking those medications just to get high?" And at one time in 1980, Arlene was having a very severe flare-up. And I mean, she was having extreme, excruciating pain in every joint in her body. And so she called the emergency number, and then the referral actually contacted her doctor, but her doctor, instead of being concerned, was just annoyed, and their relationship kind of fell apart after that. But after that, we went to a doctor in Marin County, and he was her rheumatologist. He was her doctor for, I think, till 2007. So from around 1980 till 2007, she had the same guy, and his care, I would say, was probably maybe what we would more expect from a doctor these days. In that he says, okay, well, let's give you what you need, and he was also flexible if she was having a particularly painful period or had a flare up or maybe holidays and vacations, maybe he'd give her a little more extra just to, just in case. But then, they'd always return back to her kind of base level. And he said, he just monitored it, and it was very sane and rational in a compassionate way. So I think maybe we were outliers in that regard, in that we weren't aware of all the arguments that have developed since then. So, I mean, they did give her a completely different regimen of pain medications in 2007. Well, she didn't get her surgery for she should have got her surgery probably in June or July of 2007, but because of a dental infection, she didn't get it till December. And so in that time, her surgeon would later describe the disintegration of the cement in her hip. He described it like a war injury. He said it was like shrapnel. So she had a kind of a war injury type with shrapnel in her hip from at least June until December. And so her pain was extreme during that whole period. And in those days, they were actually, in this area in California, they were actually giving appropriate, pain medication. So they would give her like Dilaudid and keep her comfortable. I mean, she couldn't, she was still in a skilled nursing facility for between, I think, September and December. Well, she was moved around to different facilities, but she did get adequate care, and we didn't hear any of this stuff about drug overdoses or opioid epidemic or anything about that. She was just receiving decent care. It wasn't until but they did switch up her medication to include things like, I guess, Dilaudid, and maybe they tried oxycodone, and for a while she was trying some sort of extended release, maybe a more powerful or different version of OxyContin called Opana ER, which didn't really work for her. They tried a lot of things, methadone, but anyhow, so her pain care was really not quite as good, even on higher dose opioids after her surgery. But we figured, well, maybe it's because she built up higher tolerance because of that extended period where she wasn't able to get surgery, and they had to treat her, this continuing pain, which they had to just wait till her dental infection cleared up. And then in 2018, that is actually the first time we'd ever heard terms like opioid. Maybe were vaguely aware of something called the opioid crisis because of TV and stuff, but it wasn't presented to us as a reason for her being tapered off of her opioid pain medications. We didn't hear that as a reason until October 2018, maybe October, December, November, December, because that's when I started contacting our political representation. And they would say, well, don't you know? I'd say, well, doctors are cutting back on, patients' pain medications. And our political representative happens to be the Assemblyman Jim Wood, who's the chair of the health committee in the California State Assembly. And they would say, well, it's the opioid crisis. And I'm going, what does the opioid crisis have to do with her getting her pain medication? She's not a drug addict. She's not a junkie or whatever. And then her doctor was the doctor that she'd been seeing. Oh yeah, at the beginning of October, all of a sudden the day before her appointment, we found out, oh, you're not going to see this doctor. You're going to go see this doctor. And this doctor that she'd had for, I don't know, 5-6 years or something, was the state DOJ, DEA, maybe the FBI were going after him, and the state medical board, and he was out of business.
Wow.
And he's charged with 4 degrees of second-degree felony murder. That was going to be California's big case. They were going to use this as a wanted to really publicize this case. At the time, Xavier Becerra, who's now our HHS secretary, he was the AG of California, and he also put out of business other good doctors in California. But let's see. So in any case, we went to this new doctor who was definitely more in the anti-opioid zealot category, and he was a state chapter president of American Society of Interventional Pain Physicians. And I should say that I think he's maybe an outlier in that group, because he was a rabid kind of adherent to the ideas of this group PROP, Physicians for Rational Opioid Prescribing, which is, some of the more famous people are Andrew Kolodny, Ann Lemke, Jane Ballantyne, and he was saying, hyperalgesia, which is this contention that with the higher your opioid dosage gets, the more it increases your pain. And he said, yes, that's 100%, across the board, and it's scientifically proven. And he was very reluctant to maintain her pain medications anyway. He did a very quick taper, and she suffered for it. There were times I was thinking, boy, she's not going to make it. It was brutal. But we only saw him for a couple months, because then he was saying something about, he said, the 2016 CDC guidelines for opioid prescribing, he said he's following those, and I never heard of those things. So I kind of looked them up. I found this thing, a pocket guide, and it said something about think that they should prescribe over 90 MME, then they should, they should write down the justification for it. And I said, well, I thought to myself, that doesn't sound like it's a requirement. And so when I pointed that out at the next appointment she had with this new doctor, they got very upset, and we were discharged and sent packing. He didn't like that.
Was it about that conversation that led to that outcome? Did they simply not like you referencing the guidelines or interpreting in a way that was different than how they saw it? What caused that outcome?
Well, maybe things leading up to it were, since this was all kind of new to us, and we were going, what is going on? This makes no sense at all. If we'd ask a question, he said this several times. He says, I'm not going to debate this with this. I'm not going to debate this with you. That's just how it is. And he would sometimes see us, and then sometimes we'd see his nurse practitioner. Actually, I think I might have said that. I might have pointed out that line. I don't remember if it was to his nurse practitioner or to him. But he came in one point and said, my nurse practitioner is feeling threatened. And I'm going, what? I thought, well, maybe I sounded angry, because I think sometimes I was getting a little, maybe a little heated, because she was doing very badly, and they were doing something, they were hurting her, I thought, for no reason. And so I thought, well, maybe I came off as being too aggressive. So I said, well, I'm very sorry and I apologize. And so maybe some of that kind of stuff led up to it. I don't know, but I was just trying to say, well, this is what you told me. You said the CDC guidelines, and this is what they seem to be saying. They seem to be saying that you don't have to stay under 90 MME. And
it sounds like a rational, reasonable response, where as a patient advocate, you are discussing guidelines that was referenced in a previous encounter. Often what I find is that many chronic pain patients and many chronic pain patient advocates, animosity or being a difficult patient advocate, how much of this gaslight themselves into thinking they did something wrong, or they're projecting a certain degree of, do you think the outcome would have been different?
Well, I don't know. I don't think he would have been dissuaded because it seems that there's so much money involved in drug treatment for substance use disorders, and they seem to be wanting to turn chronic pain patients into substance use disorder people, and nothing that you could say. I mean, in California, they barely acknowledge the existence of chronic pain patients. At least Assemblyman Jim Wood, he's made a couple little tiny comments. I mean, I've searched all over to see if he has some extensive views on chronic pain patient treatment, but he doesn't. He just says, well, we don't want to hurt them, but he's really bought into this the prop philosophy, which is, I later discovered that he's pretty tight with some of the people in prop. Anna Lemke in particular. Anna Lemke and Keith Humphreys formed a group at Stanford called the Stanford Network for Addiction Policy, and they brought in people like from West Virginia, like cities in West Virginia that are like the poster children for drug addiction and drug mortality rates in the country. And that's kind of the model, I guess, that Jim Wood is. Well, I don't know if he actually believes it, but he certainly uses it in his speeches to scare the populace that something has to be done and that he has the answers.
As such as one individual advocating for his wife, going through one set of experiences. When did you see that this was a larger play, that there were more factors influencing your patient experience than just your physician-patient relationship?
For me, it's slowly developing. Like little clues were coming, like over the past few years, little clues come in, and they stick in the back of my mind. And this kind of information is starting to come in more and more. In fact, today I just found out. One of my big focuses has been I've been realizing the effect of news and entertainment media and the influence that they have on brainwashing everybody in America, and by extension through probably most of the rest of the world as well.
It can be outright devastating. I want to talk about moments of gaslighting. I want to characterize as a patient with substance use dependency. How was that issue brought up? Was its role on the patient experiences far more pervasive than we'd like to admit? And for patients who are stigmatized, talk about the first time you were in a patient encounter when your wife was being cared, indirectly stated like, hey, your wife may have something, dependency patient.
So nobody's been able to actually say there's nothing wrong with you, it's just in your mind. But it's more subtle than that, I would say. Like in the past 4.5 years or something, she's been to the ER 3 times, and actually, and 2 of those times she coincidentally saw the same doctor in the ER. Now, and the oldest time, like maybe 4 years ago, she went in for some like abdominal pain, and anyhow, this doctor was very kind to her and treated her as you would expect a caring doctor would. And then she was admitted to the hospital. It was actually the nurses when she was in the hospital that ignored her existing care plan and cut down her opioids. But when the COVID breakout was starting, she had extreme neck headache pain in the back, and she coincidentally saw the same doctor. So in the intervening years, I guess this doctor must have been educated in this new way of thinking. And when she was trying to describe this neck and head pain, her recollection is that he was just standing there, kind of going like, "Right, yeah, sure. Well, I can't give you anything." And he said, "It's probably a tension headache." And I said, "Well, I looked it up on Google, as everybody does, and I know that's not the most accurate way to find information, but it did. There were indications. It would seem to say it's an arthritic headache. An arthritis headache is you Google it's probably a tension headache, just . And when we went to see a rheumatologist later, he said, "Yeah, it's an arthritis headache." So it was interesting the change in attitude of the same doctor
When that doctor, and no need to name names, made this obviously incorrect diagnosis of tension headache, could you tell that he was not being honest with you? Like, could you tell in his own mind he was not being straightforward with you?
No, I don't recall. Let's see. I don't know. I just recall him saying, "Well, I can only give you." He would have given her something, but it would be it was almost nothing, like maybe a half of a tramadol or something. I don't know. I forget what he was offering. I said, "Well, this is what her pain management is giving her. What if we call them? What if you contact them?" He said, "Okay, well, I'll call them." So he said he was going to go call them, and then I don't think he did, though. And when they went out to check later, and they said, "Well, no, we haven't heard anything." I think my impression is that doctors like that in the ER and some pharmacists, they give you lines that are maybe scripted, or I don't know if they just make these things up themselves, but sometimes there's a similarity, at least with pharmacists. They tell, I've seen videos from 2005 where a pain patient was talking to a pharmacist, and that pharmacist said that to that guy in 2005 all the same thing that a pharmacist about a year and a half, 2 years ago said to me. Yeah, so I just recall he said he couldn't or would. Oh, he said the pain management community here has asked us to not give their pain patients anything. And of course, when we asked our pain management,
it's unbelievable.
Yeah. It's like somebody's physically hurting your loved one, and you have to just sit there calmly and smile.
Where do you draw your sources of strength, and what advice would you give to them?
Oh, I don't know. I just keep learning as much as you can. Something that's come to my attention lately is listening to a podcast from Claudia Morandi and Bev Sheckman at the Doctor-Patient Forum, which those people they're very good. They know a lot of stuff. One of their recent guests was somebody from the addiction community who has a theory on addiction, which was brand new to me. I think it's called the freedom model of addiction, and I forget somebody, Michael Sheeran or something like that, and I forget the woman's name, but it strikes me as being somewhat similar to Maya Silovitz, she's from the addiction world, but she's been a really incredible advocate for chronic pain patients. I mean, she's written many articles, but she also does not agree with this disease model of addiction, which is I think is being put forth by Nora Volka out at National Institutes of Drug Abuse. But this whole issue, the reason why I think chronic pain patients should be taking an interest in addiction issues is because it's always put in our face that the reason why you're being cut back is because of addiction. People are, people getting addicted, and now people are dying in ever increasing numbers. And so, if what Claudia, I think, and Bev Sheckman were saying is that we really need to align with the addiction community, even though all their views may not align with ours 100%. Many of them do. I mean, in general, the war on drugs has been a complete epic failure, hurting both addiction and chronic pain communities. And so there's a lot of details. I think one of the things that's hurt us a lot is the journalists, people who write books like Sam Quinones, Barry Meyer, Patrick Radden Keefe, and Beth Macy, who I've talked to. She's a nice lady, but I think she has a lot of errant notions. There's actually a new movie that's making the rounds at the film festival. It's now called Anonymous Sister, which is brought to my attention by Twitter, Carrie on Twitter, who's she's a brilliant person. But so much of the bad treatment, I think, of chronic pain patients is justified by people who say, well, look at Purdue Pharma and look at the addiction rates. And people are always pushing this information that they get from these books and these things on TV, and the general public thinks, you touch an opioid and you're going to get addicted. And that stuff, I think, is just killing us. So we really have to join and get the notions with the addiction community together. And some of them some of them still believe that that the 1% or less than 1% rate is, they think it's all BS. But actually, Maya Slavitz herself has said, actually, that Purdue thing about 1% or less, she says that's actually true if if you don't have pre-existing conditions. But this new podcast that I just heard from Claudia Morandi and Bev Sheckman about this freedom model of addiction, that's another twist. So I just started looking into that like yesterday. So, but I think maybe the bottom line is that it's interesting to me how these politicians have charged forward with policy and practice leaping ahead of data. That's a line I got from Dr. Cortez. He says, policy leaping ahead of data. And there's still so much not known about chronic pain and addiction, and yet they're acting like they know the answers, and they're and it's huge money.